Hi guys, welcome back to the channel. And I just gave a presentation about acute kidney injury, so I thought whatever I gathered from the case I can present it to you guys right now. So yeah, let's start off with a clinical case of a 50-year-old male patient who came with chief complaints of urinary retention since the past 4 days, and he had generalized edema with bilateral pedal edema as well as facial puffiness. Okay, so this is the case. Let's talk about how do we investigate this case. So we have to differentiate if there are any cardiac or hepatic causes which are causing the urinary retention. So we see if there is any chest pain, if any palpitations are present, if there is any dyspnea. This patient had no such complaints and no history of any heart failure, no JVP or crepitations, so we could eliminate cardiac system pretty easily. Then we came to hepatic. If he had any signs of ascites, he did not have any fluid thrill, he did not have any spider nevus or any dilated veins, so we could rule out ascites too. And post-renal obstruction, that is the thing that comes into our brain immediately because it's a 50-year-old male patient. He might have benign prostatic hyperplasia, right? Or he can have any calculi or any malignancy. So but in this case the patient gave a history of use of nephrotoxic drugs. Nephrotoxic in sense that he had joint pains and he was using over-the-counter drugs like NSAIDs without any proper prescription and without any proper dosage. So that can cause renal damage, glomerulonephritis, which can present as acute kidney injury. How do you diagnose it? Three things that need to come into our mind when we talk about kidney injury are oliguria, serum creatinine, as well as uremia. So serum creatinine is a very important indicator. It is elevated in case of acute kidney injury. In this patient, it was around 3 mg per deciliter, and it is not a very reliable marker because it can vary from person to person based on the age, based on the muscle mass, based on the diet. In other conditions of acromegaly or gigantism or use of any drugs can also impact the serum creatinine value. So other newer biomarkers are being used like kidney injury molecule, KIM. You can use cystatin, we can use interleukins. So these are the other molecules that can be used instead of serum creatinine. But in acute kidney injury, in this patient, how do we go ahead? So he has complaints of elevated serum creatinine and oliguria. Oliguria is nothing but less than 300 ml output of urine in 24 hours. So these are the complaints. So we eliminate the pre-renal causes. If there is any volume depletion, we give him saline. If there is any heart failure or if any cardiac cause is there, we have to treat the underlying cardiac cause. We can give diuretics. It's not a pre-renal cause, or if it is a post-renal obstruction, immediately we have to relieve the obstruction. If it is a case of calculi or if it is benign prostatic hyperplasia, relieving the obstruction is very important. But if it is a renal case, we have to understand what type of disease it is. Is it glomerulonephritis? Is it vasculitis? Is it acute tubular necrosis? How do we come to a diagnosis? The diagnosis can be achieved with the help of urine microscopy. In urine microscopy, you can see casts, which are red blood cells, RBCs or WBC or waxy cells or epithelial cells. All of these are going to help us diagnose the condition. Other than this, other diagnostic modalities in case of acute kidney injury are, we can do ultrasonography. If the kidney bilaterally they are shrunk, they are reduced in size, we can come to a conclusion that it can be because of a chronic kidney disease. If they are enlarged, maybe it might be a hydronephrosis. So if we come to those diagnoses, then we can treat accordingly. If it is any nephrotoxic drug causing renal impairment, causing acute kidney injury, we have to withdraw that drug and we have to give treatment accordingly. So the treatment of acute kidney injury basically comes to maintenance of water and electrolyte balance, maintenance of blood pressure, and maintenance of acidosis. We have to treat the acidosis component. If we have to maintain the pH, and if acidosis occurs, we have to give sodium bicarbonate. Okay, that is the main source of treatment. If it is a case of RPG and rapidly progressive glomerulonephritis, we can give treatment using steroids. We can also give cyclophosphomides also. So other than this, the main thing in acute kidney injury is the most common cause of death in case of acute kidney injury. It might be because of hyperkalemia, it can be because of pulmonary embolism, it can be because of infections or uremia, hyperuremia. So the main thing that we need to take away from this topic of acute kidney injury is to diagnose whether if it is a pre-renal, renal or post-renal. Once we get to that conclusion, we can treat the patient accordingly and manage him. And we have to know the 3 criteria for acute kidney injury, that is elevated serum creatinine, uremia and oliguria, the normal values, the abnormal values will help us come to a diagnosis clinically. Then we can do ultrasonography or urine microscopy and further investigations to find out the exact cause of the disease to treat it accordingly. I think you guys got something out of this discussion, and yeah, if you want more such videos, make sure you subscribe to the channel and like this video. This is Unique World. Thanks for watching.